Friends, our world is pulling together like never before. We're making huge sacrifices to keep one another safe. Scientists are working non-stop to develop COVID-19 vaccines and treatments. A vaccine will get our economies moving. It will tell our loved ones we're safe again. But we have challenges we must address. Right now, huge pharmaceutical companies are keeping the vaccine research a secret. They're deciding how many vaccines get made, how much to charge for them, and who gets vaccinated. This will no doubt leave billions of people behind. Pharma companies are putting profit, not people, first. Yet, billions of dollars of taxpayers' money is funding their work. We cannot let the CEOs of a handful of pharmaceutical companies decide our future. We need a vaccine that everyone can have free of charge, no matter where you live or whether you're rich or you're poor. We need companies to share all their research so we can make enough safe vaccines for everyone. We need a vaccine owned by all of us. To end this COVID-19 pandemic, we need to pull together once more.
Hello and welcome to the People's Vaccine Facebook Live Town Hall. I'm Leslie Friday. I'm the Director of Content at Partners in Health, and I'm very excited to have a wonderful panel of experts with us today. I'm co-moderating this event with my colleague, Justin Mendoza, who is the U.S. Advocacy Manager at Partners in Health. Hi, Justin. Nice to see you virtually. And I want to introduce really quickly all of our panelists here. I'll go through the first panel. We'll be discussing racial and gender equity in the People's Vaccine. And then the second panel will address economic and public health basis for the public for the People's Vaccine. So first off, I'll introduce each of our panelists in the group here. We have four folks. We have Dr. Joya Mukherjee. She's our Chief Medical Officer at Partners in Health. We have Winston Duke, an actor, producer, and philanthropist. Thank you for joining us, Winston. We have Dr. Cindy Duke. She is a physician founder, medical director, and lab director of the Nevada Fertility Institute in Las Vegas, Nevada. Welcome, Dr. Cindy. And we also have Kristen Urquiza. She's co-founder and chief activist of Marked by COVID. Thank you for joining us, Kristen. And then very quickly, I'll run through the second panel as well, so that everybody is introduced here. We have Dr. Vanessa Carey, CEO of Seed Global Health. She'll be with us shortly. We'll also have Katie Bolbach. She is our Director of the U.S. Public Health Accompaniment Unit at Partners in Health. We have Peter Maberduke, who is the Access to Medicine's Director of Public Citizen. Thank you very much to everyone who's joining us. And Vanessa, there you are. So first off, on our first panel here, we'll be discussing gender and racial equity in the People's Vaccine. So first question we have, I'd love to direct to you, Dr. Cindy. And that question is, why should groups who've been historically mistreated in medicine and research support a People's Vaccine? And how do you counter the deep mistrust that this mistreatment has caused? Dr. Cindy.
You know, it's a hard question to answer at first thought, because the truth is, yes, Black and brown people in the United States, Native Americans, and communities that are in middle and lower income countries have historically been the last ones to receive any benefit from new technology or new treatments. And as a result, there is tremendous mistrust amongst these people because, you know, if we take, for example, what happened with the Tuskegee study, treatment was withheld, even though we knew of available and effective treatment. We have seen historically where people were priced out of adequate treatment and access to treatment whenever it became available. And certainly that has continued throughout the decades, including for illnesses such as HIV, antiretroviral treatment. And so I get the mistrust and I get the hesitancy. But what I'm here to say today is the reason why the People's Vaccine Movement is a watershed moment for us, just like having a COVID vaccine is a watershed moment, is we finally have an opportunity to advocate from the very beginning for transparency in the process and for procurement and equity in distribution from the very beginning. It's actually the very opposite of a lot of the conspiracies that we're hearing circulating right now. The People's Vaccine Movement is here to recognize that historically there have been a number of racial injustices and inequitable activities done when it came to dispensing medication and medical technology to different communities across the world and across the United States. And so this is why I'm just very pleased to be here today and to join this call for this recognition.
And I want to add too, I hear, Dr. Cindy, that you received your vaccine this morning. So that is a huge step, and congratulations.
Thank you. Yes, I got my vaccine this morning at 6:45 a.m. Pacific time.
That's great. It's your badge of courage right there. And Winston, I want to pull you into the discussion too. Well, what do you think about this and you know, this history of mistreatment and how that ties into people's hesitancy?
Well, I think we have to address it head on. I think we have to really first state that the reality of the moment is that a lot of people don't know how to trust the global medical system, because it's been rife with so much insecurity and disparity. And we have to acknowledge first that people of color have come second, if not last, you know, in the discussion. So for us to move forward, we have to state it and acknowledge it. You know, a lot of people have suffered from what can be considered medical apartheid, where they're just not given equal treatment, equal and fair treatment because of the color of their skin or because of their socioeconomic standing. We have to first acknowledge that and acknowledge that there has been clear disinformation campaigns online. So it's very hard for people to know what the truth is and where to find clear information around medical language and medical things. So once we start doing that, then we can start actually making the right steps forward and then really moving towards making this vaccine equitable and accessible.
I love that phrase, medical apartheid. That's great. And it reminds me of kind of the clinical desert that our one of our co-founders, Paul Farmer, talks about, right? And Dr. Joya, I know you can provide some perspective here. What do you think? What's underlying that hesitancy? And can you talk about some of the mistrust, I guess, that's really makes sense, right? Considering the history.
Yeah. So I just feel so fortunate to have a couple of Dukes here fighting so publicly about racial equity. I think it's very important to have people of color leading these efforts. And after many years of working in the global South and trying to provide equitable care to people in Rwanda or Haiti or Sierra Leone, it's been actually stunning and eye-opening to see those global systems of racism and inequality in the United States. I knew that on an intellectual level, but to have seen it play out in COVID. And, I have to say it's made me grow very tired of some of the language around implicit bias or even structural racism. These things are too soft. There is an explicit apartheid, as Winston said. There is an explicit, with the profit motive of our health system, an explicit acceptance that people can die as long as they're Black and brown. And an explicit, even hastening death through the restriction of resources, through mass incarceration, through the abhorrent racial use of the death penalty. And I just feel like when we say there's mistrust, it puts the onus on oppressed people to trust a system that has explicitly robbed them of dignity, explicitly impoverished them through redlining, and ghettoization in communities, through over policing Black communities, through mass incarceration. So it isn't, to me, about getting the Black community to trust the medical establishment. It's about rebuilding a society that has justice and equity at its roots. And it's sickening to me to look at the COVID statistics and see that, 3 times more African Americans are dying from COVID. Race is not a biologic phenomenon. Racism is a social phenomenon, and we've created race as a way to oppress people. And so I just feel like I was so glad. We're all so grateful to have Dr. Winnie now at UNAIDS. She's a great AIDS activist. She's been a vocal, outspoken, person who's been working for equity. And I've been lucky to see this happen in the AIDS movement over time, where a real fight that said, we're not going to just let this innovation trickle down to the millions of people. And how do we do that? We try to get rid of patents. We try to have transparent technology. We try to spread it so more and more people can make vaccine generically and branded, and not just look at this narrow funnel of 1 or 2 companies that say, oh, we can't quite make enough. It's like, well, give it to someone else then. Because that's what we did with antiretroviral therapy, and it worked.
It's great. I want to pull you into the conversation too, Kristen, and I know you have a very personal story that you've shared a number of times, right? And tying that into the second question that we had here, how will a people's vaccine protect communities, including Black, Indigenous, and Latinx, who've been disproportionately affected by COVID-19? And if you don't mind sharing a bit about your personal story, that would be great for audiences who haven't heard yet.
Sure. Thanks for having me here. My name is Kristen Urquiza, and on June 30th, I lost my dad, who was an otherwise healthy, exuberant 65-year-old to the virus. He woke up on June 11th with a fever and a cough, extreme exhaustion. And that began our June journey with this virus, where every single step of the way, I was flabbergasted by what was happening. I kept on saying to myself, this shouldn't be happening. And it wasn't just that this should not have been happening to my dad. Of course, I did not want that to be happening to my dad, but it was everything around us as well that shouldn't have been happening. At that point in time, my dad's neighborhood, my childhood neighborhood where my parents still lived, was seeing the highest COVID cases per capita in the state of Arizona, when Arizona was experiencing the highest per capita cases in the world. This was not in February or March when we didn't know what was happening. This was in mid-June, after the state of Arizona had been shut for multiple months. And I've got to say that my neighborhood, where I'm calling in from today, is over 70% Latinx, mostly immigrant, folks who are already living around the margins, who didn't have the extreme privilege of Netflix Flixing and Chill during this entire time and have been the essential workers out on the front lines. Part of my experience and my experience overall really galvanized and clarified that COVID is the single largest thing killing Black and brown people right in this moment. And I knew that in order to do something about this passion of racial justice I have, that I needed to help share my story as well as the stories of other folks out there who have been impacted by COVID, which is why I launched Marked by COVID and why I'm a huge proponent of the people's vaccine, because one of the things that we've been hearing in this panel so far is that there is a need to invest. There's a need to divest and a need to invest. And the thing that the people's vaccine does is it helps invest in communities of color, the Indigenous, Native, Black folks, to ensure that we are addressing the two Americas that we see playing out. My dad didn't have the privilege of going to the hospital on day one, like Rudy Giuliani got to do, or the president. He was told to stay at home for 5 days until he couldn't breathe. We need to make sure that we do not have a healthcare system that basically says people like my dad are expendable, when in fact, every single person, the more than 300,000 people who have died, are irreplaceable.
That was really beautiful. And I want to thank you, Kristen, for sharing your personal story of loss and for taking action, right? And Joya, this sounds so familiar, right? How many times have we heard about the healthcare for one group of people and the healthcare for all the many more? If you want to comment on that at all.
Well, Kristen, first of all, just to say, I'm so sorry to hear about your father. And, I'm grateful that you've used your grief to channel it into this kind of action. I think that is an important component of how we grow as a movement for justice. So, my deepest condolences. And I think you're so right about the Netflix and chill. I mean, I get to sit in this beautiful place with all my plants. I've been sitting here. Oh, poor me. I'm working from home. No, I have tremendous privilege, internet, salary support. I don't have to go out. And you look at what are called the essential workers in this country, and many of them are the people who are otherwise considered disposable because of the racism that has not only impoverished people in our country, but around the world. I find this thread of racism the same in how we think of global development, as if, Cindy and I were talking on a call a while ago about infertility. There's an idea, well, there's no infertility in Africa. Of course there is, but it doesn't matter if people, can't have a child. Or cancer. I have a child who had cancer when they were 2.5. That child would have died in your community, probably, Kirsten, and in, the community I work in Haiti. So this is just not an acceptable 21st century for us to have, and it's built on a 20th and a 19th century of building wealth on the backs of brown and Black and Indigenous people. And I think we should say we've had enough, and that COVID is, to me, an object lesson in racism. And, if you look at what happened, I'm just going to say this last piece at Irwin Detention Center, right, where women were being forcibly sterilized, who are Latinx. People are being incarcerated. The whistleblower, not surprisingly, was an African-American nurse. And so I think we need to say, who are our allies? Who are the people who are going to fight for justice? And the way to do this, there is plenty of manufacturing capacity for this vaccine in the world. There's plenty of it. When they say they can't manufacture enough vaccine, that's because Pfizer can't. But if they were to turn over that technology to India, China, South Korea, South Africa, Thailand, we could manufacture plenty of vaccines. So this is about control of this resource, this quote unquote intellectual property, which we paid for, our tax money paid for, the tax breaks that bankrupted our country have paid for. And so this is just a fake argument of scarcity.
And
I think it's
Dr.
really
Cindy,
important that we
go ahead,
continue.
Winston.
I was just going to say it's really important that we continue making the conversation about the people that we're trying to affect, because all the powers out there are trying to take away faces. They're trying to take away the faces and the stories and the narratives and the real actual impact that these isms that we're talking about, these large lofty ideas that we're talking about, they're trying to take away the real impact that they're having on families, that what these families look like. Even the word essential is dehumanizing. You know, it removes the human component from families that are Latinx, families that are mixed, that are mixed documentation families, where you have children who are documented citizens, but their parents might not be, but they don't have the luxury to stay home and work. They have to be out there. They have to be out there, you know, cashing things, washing things, mowing your lawns, and making sure that, you know, your world is still working. And these are the real people that are being affected. And corporations and these ideas of numbers. When we hear that over 200,000 people died in the United States, in a world of social media, 200,000 doesn't sound like a lot when you're thinking about likes or views and things like that. But you have to remember that these are people, that these are families, that these are individuals. So we have to really bring back the human component. And that's why it's really important that we've even structured the conversation in saying that it's the people's vaccine. Like, we are fighting for human beings here. We're fighting for people. We're fighting for families. We're fighting for people who have actual lineage and people who depend on them. So it's really important for us to really come back to the reality of the moment, what it looks like, and who's really being affected.
Thank you, Winston. And
And
I saw you
precedent.
shaking your head. Yes, Dr. Cindy.
Yes. And there's precedence for it. You know, I know there are people out there who are hearing us talking about intellectual property and trademarks and saying, well, they must not know what they're talking about. But there is precedence for this. And, you know, Dr. Mukeji actually referenced it with what Brazil did back in 1997 when they decided to make patents on antiretroviral therapy for HIV public property. And in so doing, they were able to cut the costs of antiretroviral therapy for HIV and turned HIV in Brazil and other countries that they then made those medicines available to. They turned it into something that people could now survive. Prior to that action, you know, it was too expensive to afford antiretroviral therapy. And so HIV infection meant a death sentence in many countries across the world long after we knew how to manage it. We knew how to keep people's viral loads undetectable. So we do have precedents for those who are wondering. Brazil was able to save over $1 billion US just from doing that. The truth is, if you consider our low income and middle income countries, the World Health Organization has actually looked at this, and they're forecasting that we have at least almost $5 billion in deficit in terms of what we will need to even start matching the COVID vaccine needs across the world. If things don't get better, even though I am very pleased to say that as a Black immigrant woman, I received the COVID vaccine today, it wasn't lost on me as I was getting my vaccine that I welled up with tears, because I realized that there are other people who look just like me who may never get access to this vaccine for another 5 to 10 years if we don't act and if the people's vaccine movement isn't successful.
Thank you for adding that, Dr. Cindy, too, because as we're all queuing up, right, to get our vaccination, it could be years for many countries to even see a vial come through. Winston, I want to direct our last question. I know we could talk forever, but we do have to switch over to the other one, the other panel. But the third question here I have, and I would love to hear your thoughts. What effects will a people's vaccine have on gender-based violence? I know this is a particular passion for you, Winston. So what are your thoughts here?
Well, of course, again, we have to paint a picture of the reality of the moment. And the reality of the moment is that gender-based violence has increased under quarantine, has increased during, the pandemic, because you have women who are in the home now 24/7 or just more with their abusers, and they can't leave. And opportunities that they might have had to leave when that partner was at work, when that partner was out with friends, when that partner was just not present, they're now around a lot more often. And then all the stresses of the moment is now compiled through that individual, that male figure that might be very insecure, and his insecurities are heightened now because he might have lost a job, because now he feels like his masculinity is threatened because he can't provide in a way that he feels comfortable or knows how. And now you have young girls and wives and daughters and all these people who are now trapped in these homes with these people. So we have to paint a really clear depiction of the moment, and then show that this vaccine, having access to this vaccine, can get us to a place where we can get young women, girls, mothers out of the house. They can be back in the workplace. They can have access to be leaving the home more often, back to school, and back to actual things that would help them just escape these moments. So there are a lot of byproducts and so on that will come out of having access to this vaccine.
And Kristen, if you could address this too, in your community, I believe you said more than 70% of your community is Hispanic and Latinx. How has this, if at all, from what you're seeing, affected the community where you're at?
Yeah, I mean, this community has been bearing the brunt of the pandemic cases as well as pandemic losses. The only other community that is seen as bad of cases here in the state of Arizona is the Navajo Nation, so indigenous communities, and a zip code in South Phoenix, which is a historically Black zip code. So we're an amazing case study for how people of color have been shouldering the cost of this pandemic. And the availability of a people's vaccine really gets the heart at what we've all been talking about here. It's about ignoring the system that is in place that keeps us in this stratification of one person more important than the other, and actually allows for untraditional investments in the people who have been experiencing the most impact. And so whether it's women, whether it's Native folks, whether it's my Hispanic community, it ensures that we are in a priority. We are centered. And that is something that, we demand, quite frankly, given not only this pandemic, but what this pandemic has exposed. Very clearly, it's moved from the intellectual to the emotional of our communities have been left behind for decades, if not centuries.
Thank you. And I want to give the last word, if I can, to Dr. Cindy here. And knowing day to day, you sit down with families. How could this people's vaccine give new hope for women and partners, especially considering gender-based violence? Is there something that you would like to add from where you sit too?
From where I sit, it's critical. It's operation critical. We have people who are struggling. We have people who are struggling with unprecedented numbers of mental strain. This pandemic, we all know, we all feel, COVID fatigue. But in a multi-generational household, in an immigrant household, in a female-led household, households that are single-parent-led, the stress is even more. People are afraid of what happens if they were to fall ill and they could no longer provide for their household. What would happen to their children if they were no longer able to provide for their families? What will happen to their communities, their parents? People are left making some really unfortunate choices even, out of fear and out of emotional strain. We know that there are communities who may not survive this pandemic if we're not able to help curb the spread of COVID-19 as soon as possible. And so it's really important that this people's vaccine movement take off and we actually get results from it.
Thank you so much. Thank you to each of you, to Kristen, to Dr. Joya, Dr. Cindy, and Winston. Really appreciate your thoughts and your comments, your advocacy, and your wise words today. Thank you so much, and to all watching. Now I want to hand over to my colleague, Justin Mendoza. Justin, are you there with me?
Yes, thank you so much, Leslie, and thank you to everyone on the panel for joining us for the first half of the show. I think the remarks we just heard from our colleagues and friends and such amazing activists and advocates from the movement really do underpin the long-standing health equity issues that we face when addressing this pandemic and so much more. This next panel, I'm excited to introduce you to, is going to take a look at the economic and public health consequences broadly with the people's vaccine, and why this vaccine and making sure it is accessible and not just another cog in the continuous process of corporate profitability in the vaccine industry is incredibly important to the future and how we respond to this outbreak as we go. So just for the folks that are tuning in now, we'll be joined by Dr. Vanessa Carey, the CEO of Seed Global Health, Sona Essien, the project manager of Free the Vaccine, Peter Maberduke, the Access to Medicines Director at Public Citizen, and Katie Bolback, our Director of the U.S. Public Health Accompaniment Unit here at Partners in Health. So excited to chat with you all and to dive right in. So just to get us started, let's start with the idea that if vaccines are just not contributed equitably, and I should say this question's for Dr. Carey and Katie first, but then the other folks continue as well. But if vaccines are not distributed equitably, what impact do we think it would have in the economy, particularly for people of color, the working poor, and immigrant communities in this country? Oh, and abroad.
Thank you so much. Thank you so much for letting me join you. And I think I want to just start by actually acknowledging Kristen's story and what this means, because as we go into a panel right now where we're talking about what the global impact of this pandemic and a failure to distribute a vaccine equitably is for either a national sort of impact or a global impact, I still have to acknowledge that COVID is also very personal, right? We lose people to this disease all the time. And every single family, every single person has been vulnerable to some aspect of COVID. How vulnerable you are certainly does vary depending on where you're born, what your surroundings are, the color of your skin, your economic status. But the loss, if you do lose someone, is always personal. And I just want to thank her for sharing that and for motivating that into change that is deeply needed in this country. I mean, I think it's very interesting because people don't realize, I think they underestimate the extraordinary power of Black and Brown and Native populations in the United States, and what that means for our economy, for the fabric of who we are as a country, and for how we were founded and how we work. And I think that there's really an undervaluing of that. But to speak in pure economic terms, I mean, the spending power of Blacks, Native Americans, and Asians in the U.S. is about 2.4 trillion, and Latinx are about 1.5 trillion in the United States economy. So when we think about who these people are in terms of what they give to our economy in a buying power, it's tremendous. But that's being very I'm being extremely fact-based, kind of insensitively economic. The end of the day, we're also talking about folks that make up huge amounts of our essential workforce. Black and Brown people, I believe, are about 50% of our essential workers in food and agriculture, and over 50% in industry, commercial, and sort of residential and services provision in this country. And so it really goes to the fact that if we are talking about this entire country's well-being, and for all of us, no matter who you are, what position you're in, if we want to prosper, if we want to thrive, if we want to get ourselves back to some semblance of normal, we are going to have to think about the fact that no one is safe until everyone is safe, and that we are always going to be vulnerable. And this pandemic has absolutely devastated Black, Brown, and Native communities more than any other group in this country. And that, though, isn't because of genetics. That is 100% rooted in structural violence, in our history, in our politics, our policies, and our failure to really embed our country and base our country on a system of equal opportunity and justice that is rooted through investments in health, in education, and really in equity. And I think that the major divide in this existential moment we find ourselves in is very much rooted in that division and that schism that we have to figure out. I think globally, though, we also fail to realize, and I work as the CEO of Seed Global Health, we partner with governments in order to be able to support them to train the very needed backbones of their health systems of doctors, nurses, and midwives, to partner with those community health workers and to be able to train their successors and across the health spectrum. And as we've done this work, one of the things that we've realized and are seeing is that the vaccine that has been produced and approved to date, which has really been the Pfizer and the Moderna, those vaccines have been primarily purchased by about 7 or 8 countries around the world, and those are the richest countries in the world. And if we don't equitably distribute the vaccine, if we distribute the vaccine only to about, the richest countries in the world, we're only going to prevent about 33% of subsequent deaths. Whereas if we were to buy into this idea that we are all safe when everyone is safe, or that idea that no one is safe until everyone is safe, we could prevent up to 65% of deaths globally with an equitable distribution plan. We need to remember that our manufacturing comes out of Southeast Asia, out of South America, that our raw materials right now are coming from Africa and from other countries. We are tied in a global economy in a small world. So economically, there's justification. But by far, for me, there's also the reality that we have to decide who we want to be as humans in this moment. What is our legacy going to be, and how are the future generations going to look back on who we are and the decisions we made in this moment? And there is a right thing to do, and there is a not right thing to do. And I think we have to make that clear choice. And so I am grateful for those advocates, Kristen, Partners in Health, Dr. Duke, Winston Duke, all of you, Katie, everyone who's being a part of this system. And I know I left out names and I apologize, but it's this idea that we have to come together in this moment to really create the values we want to see.
Right, absolutely. And thank you for raising all of those points. I think you're completely right. This is a moment for joint advocacy and for us to really build a better world vision. So passing it to Katie, can you describe for us a little bit about what does it look like to see more equitable distribution?
Sure. Thanks, Justin. Thanks, Vanessa. I think we've been thinking about this at PIH in terms of the U.S. distribution, at least with our team, around not just sort of prioritization decisions made on allocation policy, which are essential. And we had some encouraging news yesterday in terms of the prioritization with vaccine rollout, really focusing on essential workers. But you've really got to back that up with preferential resourcing and operational support to be able to reach hardest hit communities. There's some really important lessons that we need to learn from failures of sort of testing, COVID testing in the US. Which were not targeted at hardest hit communities of color, reaching essential workers. We're too often clustered in wealthy, white communities. And so, for example, we're working in Montgomery, Alabama right now, where the only free testing available to people is Mondays, Wednesdays, and Fridays from 2 to 4 p.m. That really limits, that tells you a lot about who's going to be able to access testing. And so as we think about the vaccine rollout and ensuring equitable access to vaccines, there's, the critical set of questions around policy, prioritization, getting vaccines on the ground, but there's a whole other set of important questions about how we ensure we're really reaching the most vulnerable, we're reaching communities of color, we're reaching essential workers first and foremost, preferentially with this rollout, not as a second or third order consideration. And so I think happy to get into more specifics about some of how we're thinking about that, but that needs to be a concern today and yesterday, not just after sort of high level policy decisions are made about allocation.
Absolutely. Yeah, and of course, ongoing right now are lots of discussions about what those big policy decisions look like. But as both Dr. Carey and earlier, I believe Winston Duke brought up, there's this large concept around kind of vaccine apartheid, or this idea that large wealthy nations are buying up most of the vaccine. And so, Serna, I know at Free the Vaccine, you all have looked at this and some of the other areas and issues there. How do you see that issue, and what would you say are some of the solutions we should be looking at?
Yeah, thanks. So I am a project manager for Free the Vaccine, and we have been working since March, actually, on trying to radically widen access to the COVID-19 vaccine, in addition to diagnostics and treatments. So right now, I think Dr. Carey mentioned that the majority of available vaccine doses have already been purchased by high-income Western countries. And we really have to think about how that's going to impact eventual access to the vaccine for countries in the global South that are populated with a majority of Black or Brown people. So we've been discussing and having conversations about what we call vaccine sovereignty. And that is essentially the idea that individual governments are using public funds to obtain priority access to potential vaccines. So high-income countries are then getting a disproportionate share of vaccine doses, whereas low and middle-income countries are having to wait their turn for an eventual vaccine. And that does not look like equitable distribution at all. When we talk about the ways in which COVID is impacting Black and Brown people in the US, and when we talk about access to medicines and how Black or Brown people experience decreased access to medicines in the US, we see similar trends on a global scale. And that is because of existing legacies of white supremacy and nationalism. And we're seeing the same thing being repeated with a lot of white, wealthy countries buying up this vaccine. So in order to prioritize equity on a global scale, it's important that we emphasize that the vaccine should be available to all. And in addition to that, it needs to be sustainably priced, and it needs to be free at the point of delivery. So when we talk about access, of course, we have to consider a lot of legacies. So in the US, we're considering the legacies of racial trauma inflicted by the medical system, but we also have to recognize that that same legacy, especially tied to colonialism, exists on a global scale. And when we consider this, then we have to make additional plans that consider all of these legacies and consider the way that they will impact the way people can access these vaccines. In addition to trying to prioritize access to everybody, we have to prioritize sustainable pricing. The reason why wealthy and Western countries have been able to buy up all of these doses of vaccines such that they're able to vaccinate their population 2 or 3 times over is because we have relied on a system, essentially a free market system, where the person with the most money can access the most vaccine. However, this approach is not going to end a public health crisis that affects everybody equally, regardless of how much money they have in their bank. And so we need to focus on sustainable pricing. And sustainable pricing essentially looks like setting a price for a vaccine that will not bankrupt governments and individuals, but that will be affordable for many people across the world. And that is a central pillar in terms of widening access and in terms of making sure that people around the world and in the global south as well have access to the vaccine. And I think a point was made that was really great. We have to really look at access from the beginning rather than at the end, after a vaccine has already been made and after countries have already bought up so many doses. We have to think about pricing and who is going to get access to a vaccine from the very beginning, because history has shown us time and time again that when we leave people in low and middle income countries as an afterthought, that has really disastrous outcomes in terms of a public health perspective.
Absolutely. And underlying the system of pricing and the way that things are built and set up so that the highest bidder can buy them is, of course, an entire regime of intellectual property and the current vaccine production pipeline. Peter, I'm going to turn to you now. Can you describe for us a little bit of what Public Citizen sees in this fight and how we should be thinking about the people's vaccine from a new business model perspective and or how we transform the industry?
Thanks, Justin. Well, there is an alternative to scarcity. The Serum Institute of India, which is the world's largest vaccine manufacturer, estimates that on current capacities, it could take 4 years for vaccines to reach all of the world's people. And the consequences, of course, for people living in developing countries who will be at the back of the line is absolutely horrendous. But it doesn't actually have to be that way. No corporation can manufacture at scale sufficient to serve the world. But together, if we activate manufacturers around the world, if we activate the public-private facilities jointly managed by the US government and others, if we share technology with the World Health Organization, we can significantly augment capacity and accelerate production and thereby shorten the pandemic with benefits to all. When I think of the fact that we haven't done this, and the consequences for loss of life globally, it makes me really angry. And it just comes from this place of deference to companies and trusting them to do what is in the world's interest. But we actually need, for example, President-elect Biden and the next administration to restore US government leadership and say, we have unique capacities to shorten the pandemic by expanding supply. We're going to put all the resources of the United States to work to get that done. The World Health Organization has set up a program called the Technology Access Pool that is just waiting for technology holders to contribute. You know, what we'd say to patent holders and those who rely on exclusivities to make their research and development contributions is that in this moment, humanity can afford to pay you for your technology. What we can't afford is exclusivity and secrecy blocking access to the know-how to make vaccines at scale. So it's time for exclusivity to be over. It's time for us to see this as the great challenge of our time, right? We could save the world if we all work together and say, what capabilities do we have to expand manufacturing capacity and shorten the pandemic? The next U.S. government can do this under existing law. There are a number of laws that exist to facilitate technology transfer, sharing technology with the world, and to make it possible to expand capacity. So we should just do it. We need to indicate here, I think, the message for folks on the call more than anything else is it can't be only about equitable distribution. It also has to be about expanding supply. And I think we have to resist this notion that the scarcity is inevitable and push back and say, we're not using all the tools at our disposal to make vaccines quickly available, safe and effective vaccines quickly available to everyone who needs them through a project the world over.
Excellent. And so imagining a world with where we have solved for the scarcity, or where we solve for more of the scarcity by increasing the total number of doses, the amount of vaccine available. Dr. Carey, how would you think about, still as we think about the global access pieces of this, where would governments need to look in terms of how they should prioritize and think about even an expanded pool of vaccines? So I think even under the world that Peter's describing, it's not tomorrow that we have enough doses for everyone. It's still a ramp up time. How would you advise folks to think about how to prioritize?
You're asking me to solve like the $1 million question.
I am.
So I think look, this is where, I think this is the grapple is who and how do we equitably distribute vaccine when we're trying to scale up the amount of doses available across the board. And I think that, the prioritization of frontline healthcare workers and those that are on the front lines are critically important. They've been infected at a higher rate given sort of the general exposure. And they are obviously vulnerable and essential. As somebody who spends a career training healthcare workers, for me, this is the essential way for us to be able to respond, not just to a pandemic of COVID, right? But the ongoing pandemics of HIV, of maternal mortality that are happening around the world, of chronic diseases that are killing people, of all of these pandemics that are kind of the slow burning ones that are also killing people. So you need the healthcare workforce critically. And then I think it makes sense to think about how do we, vaccinate those that are the most likely to end up in our hospital. And I want to put an asterisk on that because one of the things that Kristen outlined eloquently was the fact that not everybody gets access to a hospital in the same way. And I think you have to think about who those communities are too, is where are the communities that may not have the ability to access the healthcare system readily, who are very vulnerable to COVID and who are, who are important to be vaccinating as well. And those discussions have to be brought into place also when we think about who we're trying to protect and how to do this equitably. The reality is that there is a scarcity in this initial phase, and we are just going to have to grapple with that. But I think if we can bring together a multi-stakeholder, truly diversely represented coalition to grapple with these issues and to come up with the best set of recommendations and practices, taking into account who is dying from this, who is the most likely to be able to have access to resources to care for it, or who is most vulnerable in the sense that they don't have the ability to seek care or will get the same access to care. And to sort of bring in some of those additional triage questions, it would be really important. But I think in addition to just the distribution of the vaccine, I think it's important for us to take a step back in this moment, though, and also say, as we are talking about our vaccine distribution network, and as we are talking about the networks that we need to step in and stop the dying and suffering of COVID, we should not be myopic to COVID only, but realize that just for a little bit of extra thought and a little bit of extra investment, we actually could be building an entirely equitable, well-designed, well-distributed primary care system for this country or globally that can not only stave off the next pandemic, but can provide the essential care that can prevent disease, prevent dying, prevent suffering, and care for patients and create that opportunity for all. Because health is fundamental. You can't go to school. You can't take care of your family. You can't do anything if you don't have health. But I think there's a moment in COVID as we're talking about and grappling with these issues to make sure that we're thinking about it on a more global level, about what it means for healthcare delivery overall for all. And again, to go back to that idea of how do we fix the fundamental structural barriers, and Serna said this as well, go back to the beginning, right? We are dying in the numbers we are dying because this country is one of the only wealthy country healthcare systems that could afford it, but doesn't, to have a nationalized healthcare system with health available to all, accessible to all, and to create that system. Instead, we are a private insurance industry driven system that has allowed for huge gaps to persist. And where if you map where the real morbidity and mortality of health is in this country, it maps to where poverty is, and it maps to where the healthcare system has not been expanded or made accessible. So I think there's an opportunity there as well.
Our political leaders and hearing these messages from so many voices pushing very hard for access to not only the vaccine, but a continuum of care that can take on this this outbreak, will continue to build up the political will to act and drive forward something that brings us closer to universal healthcare. Kristen, Katie, apologies. I'm going to turn to you to talk a little bit about how do we reach those communities that Dr. Carey was just talking about when we really need to find a community-based approach. How does PIH see that?
Yeah, well, amen to what Vanessa was saying about sort of this as a moment to really reflect more deeply on not just solutions for the vaccine challenge, but the more fundamental systems inadequacies and injustices that are undergirding the situation we find ourselves in right now. And I think part of that is absolutely, Justin, as you started to touch on, more community-based approaches to care, approaches to care that aren't just about, for-profit, fragmented hospital based care, but really building out our community-based workforce, community health workers, and other essential cadres of community-based workers that are going to help connect communities to clinics and to care, that will bring in supports for other social determinants of health, the things we know that drive people's well-being, like access to safe housing and food and other essential services. And so we, in our COVID response here in the US, have been working with partners across the US to address the immediate needs on bringing the full public health toolkit to bear on the response, from testing, contact tracing, now vaccination rollout, but thinking about how we use this moment in time to take learnings and sort of this moment of this inflection point we have in the US to grapple more deeply with the fundamental unfairness and inadequacy of our systems. And we hope this will be a moment to really springboard into a more ambitious and transformative movement for healthcare reform, not just healthcare reform, but health systems, transformation in the US that really puts people and communities at the center of systems and care.
Excellent. And I think a recurring theme throughout both of our panels has been that conversation about how this isn't just about the vaccine, it's the full healthcare system and how we have to address these inequities at multiple levels. Also, a recurring theme is how we have to address the pharmaceutical system and the way that these vaccines are developed to begin with. Before we move on to the Q&A, I want to just ask Serna to weigh in on any other thoughts that around how Free the Vaccine is looking at research and development that goes into this work. And yeah, pass it to you.
Thanks for that question, Justin. Yeah, so you are completely right. This is not an issue of just the healthcare system during COVID or pharmaceutical development of COVID technologies. We have already created systems that have unfortunately created a situation that is woefully inadequate for responding to the widespread scale of this pandemic. And the pharmaceutical system has shown that in recent decades, it has become a system that very unfortunately prioritizes profit over patients. And in doing so, we've seen a dearth of research into neglected diseases, into antibiotics, and into emerging infectious diseases such as the novel coronavirus. If we actually invested money at the outset into all of these different causes, instead of something like maybe hair regeneration, or something that has proven to be very profitable, but maybe doesn't have as widespread a need. If we had invested at the outset, we possibly may be in a much better situation right now when it comes to progress of vaccine candidates, when it comes to pricing of these same candidates. And that begs a question for how do we change this system? Not only how do we make sure that people have universal access to COVID vaccine and diagnostics, but how do we make sure that they also have the same access to essential medicines? Because this problem has existed for decades. And one way that we can think about it is restructuring the pharmaceutical industry to respond to need rather than to respond to promises of profit. And additionally, we have to think about how can we solve this problem of supply and scarcity. And one way that we can do that is to get our governments involved. And that can happen one of two ways. One way is for the government to enforce broader access guidelines for all biomedical technologies that have any public funding behind it. And I can tell you right now, both the Pfizer vaccine and the Moderna vaccine have hundreds of millions to billions of dollars of public funds behind them. So if the government steps in and then mandates that there has to be multiple manufacturers, so not just the brand name, but also generic options available, we could have a scenario in which the supply problem is mitigated by multiple manufacturers. And another option that governments can take is actually looking into nationalizing production. And that is something that has entered the political sphere as of late. I believe it was last year that it was this year that Elizabeth Warren actually introduced a bill to begin producing really expensive medicines that had access barriers in the US. If we expand this conversation and eventually move in a direction where goods that cannot be accessed by the public are then produced by the government who have access to the intellectual property and the patents, then we can set up a scenario where we don't have to have this kind of artificial scarcity as such a large problem. And with the widespread nature of this pandemic, we also have to look at how to solve these problems on a global scale. And looking at multiple manufacturers across the globe is one way to do that. Russia actually has a vaccine candidate called Sputnik 5. And a couple of weeks ago, they reached a deal with an Indian manufacturer to ensure generic manufacturing of their vaccine candidate. As I believe someone said earlier, but a lot of our producing capabilities comes from Southeast Asia. India is actually called the pharmacy of the world. And so using this existing manufacturing power and opening up intellectual property rights around some of these biomedical technologies to respond to such a widespread biological threat is going to definitely be one part of responding to this pandemic, but it should also be seen as a mechanism for widening access to medicines outside of the COVID-19 pandemic.
Great, thank you. And I just heard that President-elect Biden actually just received the vaccine while we were talking on this panel, so it's brand new breaking news. But I know, Peter, you had mentioned before some things that the president-elect can do, and of course, everyone who's involved with this call has either organizationally or individually been involved with the People's Vaccine Letter. Do you want to close this out with a couple more comments about what the president-elect could do on day one?
Sure. Well, so why do we call it the People's Vaccine? One reason is we actually paid for it. All the leading vaccine candidates benefited from federal research dollars, taxpayer money. We've been investing as public agencies for the past 20 years. So it's not, this isn't something that was just created in a corporation's lab without our support. We've all been working on this problem collectively as a people, as citizens, as taxpayers for a very long time. And that's how we have the vaccines. The problem with the secrecy and the non-sharing, I'll just give an example, right? So the so-called Moderna vaccine, which is really the NIH vaccine, the National Institutes of Health, a publicly funded, partially publicly owned vaccine, is very similar to the Pfizer vaccine. They're both mRNA. One of the key differences, though, is that Pfizer requires this extreme cold storage, which means it's going to be considerably harder to get it to resource-poor settings, tropical settings all around the world. There isn't necessarily any reason that Moderna couldn't just share that its technology, its storage technology with Pfizer, and greatly simplify the rollout of vaccines to people in much of the global South. It's kind of a simple fix that could save a lot of lives. And it's really outrageous if you think of it, that the only reason that hasn't happened is because of the political economy of our pharmaceutical industry and its reliance on monopoly. So when President-elect Biden comes in office, we need a moonshot. We need, a Marshall Plan, whatever metaphor you want to employ. The US government has tremendous capacity to, it's a technology owner. It owns a lot of technology behind these vaccines. We, the people, collectively paid for the research that went into these vaccines, and we have the right under existing law to have that technology shared with the world so that it is easier to manufacture at scale, so that the Serum Institute of India, so that the Developing Country Vaccine Manufacturers Network can get involved and produce for their people. So we would love to see President Biden convene a team, the goal of which is to significantly accelerate the manufacturing and rollout of vaccines to the world, using this combination of sharing technology, mobilizing the partners, mobilizing the countries and manufacturers, calling on them to contribute and build the necessary remaining manufacturing capacity. It's not going to be simple. It's not an instant. There will be technical barriers. But if you really think about the course of time that we're talking about, several years in which people in the global South will be waiting for vaccine access. You think about what the pandemic has done in the United States this year, how much harder that's going to be over the course of several years in regions where there are considerably fewer resources to apply. It's a moral imperative that the President of the United States stand up and say, we have the capacity to contribute and help fix this. And we, as the People's Vaccine Alliance, all of us together, are looking forward to working with the next US government to get that done.
And thank you to everyone on this panel. We're going to move now into a Q&A session, but just wanted to thank you all for talking with us today about not only how the current distribution and equity is so important for this vaccine, but also what it would take to expand the pool and the supply so we can move away from scarcity. Very important points brought in by everyone on this panel and the panel before around equity as well. So from the audience right now that's been following us live and sending in some questions, we have a couple for this group. The first one that comes through is pretty straightforward. It asks, what can I do, or we do as average citizens out there to advocate for equitable vaccine distribution worldwide? And Sona, I'll pass it to you to talk about that, because I know that Free the Vaccine has been mobilizing us average citizens throughout the entire movement that you've been building. So I'll turn to you first.
Thanks for that question. I think that's super important for us to be action oriented when it comes to pushing for access to the COVID vaccine. So Free the Vaccine is a completely virtual advocacy innovation hub that we launched in March in response to the first lockdowns in the US. And we have the goal of making sure that the COVID vaccine and any related diagnostics and treatments are sustainably priced, available to all, and free at the point of delivery. We have people from around the world with a variety of backgrounds, from activism, creative activists, artists, and people who have never stepped foot in any fields that would have to do with an emerging vaccine. And what we have been doing for the past 9 months now is targeting different institutions that are conducting COVID-19 research. Peter mentioned earlier the technology access pool that was spearheaded by the World Health Organization. And this technology access pool works to share intellectual property related to combating the pandemic among a bunch of different stakeholders and manufacturers that are looking to develop some either diagnostic tools, vaccines, etc. And it's what any person can do to push an institution to be part of the technology access pool is to reach out to the stakeholders at different institutions and say, you know what, I am a student at this university, or I am a resident of this community, and I think that the research that you're doing is incredibly important, but I think that the impact will be much greater if people can have access to it. And it's really important to have those kinds of conversations with different institutions, because what we've seen in this pandemic is a lot of private corporations sort of acting like they are leading the charge in creating a vaccine, when there is actually hundreds of millions to billions of dollars going into university research. And this is publicly funded research into products that will eventually become public goods. So it's incredibly important to try to push these institutions to open up their intellectual property, because they are also the ones who are leading the charge and conducting this important research that's going to get us out of the pandemic. Free the Vaccine is actually launching into our 3rd season. We've broken up into increments so that people can learn a lot and have different targets. And we will be launching our next season in the beginning of February. So you can go to freethevaccine.org and learn more about our campaign and see if you want to be part of season 3.
Excellent. Thank you, Senator. Very important work helping folks get involved in the movement directly. The last question that I have from the audience is way more upstream from fixing the downstream issues on other way around. It's way more downstream. But we know that many of these vaccines, in fact, we know the Pfizer one requires extremely cold temperatures and has a short shelf life once it's thawed. So the person who submitted this online said that they imagine that only hospitals will be set up to store the vaccine. Are there ways that these challenges can be addressed so that people in rural, less populated areas in the US and globally can also have access to the vaccine? I'll turn first to Katie and then to Dr. Carey on this one.
Great. Yeah, it's a great question. I think the short answer is absolutely. And that's a critical piece of work that many folks across the US are digging into right now, in terms of at a state and a local level, at a community level. How do we support our public health leaders and our local leadership to develop plans operationally that allow us to get the vaccine to the communities that need them the most and that are at risk of being excluded if we don't have really strong supply chain operational and logistical plans, as well as community engagement plans to be able to move quickly to ensure it's not, just hospitals, but federally qualified health centers, other community health centers that are able to deliver on the vaccine, as well as other, point of care efforts that can go even more deeply into community. So there's a question of storage, but there's a question of then sort of mobile distribution or other ways that, beyond just where vaccines are physically stored, a range of efforts that we can support and finance to push distribution down to the community level. And I think that's a critical push in front of us in these coming weeks, is to finance and support our local leaders and community partners to be prepared to do that quickly.
Absolutely, and I imagine that gets even more logistically complicated when we look outside of the borders of the United States. Dr. Carey.
No, I mean, I think I would second that. Again, it goes to the opportunity of building some of the infrastructure that becomes fundamental to delivering lots of other things, right? I mean, we can deliver Coca-Cola to almost anywhere in the world. So why can't we figure out how to just build that cold chain? And there's obviously electricity and complications to it. The truth is, though, the fastest way, at least initially, to be able to get a vaccine to everybody in every place is probably going to be thoughtful about all the vaccines that we have available to us. So it's going to be, we have Pfizer is one, but we also have Moderna, which doesn't require the same degree of very intense cold chain. And then there's the AstraZeneca vaccine that, one, has not been bought up by only 8 countries, and 2, will be able to, doesn't rely on quite that depth of cold chain. And so I think it's going to be a combination of us really building the infrastructure and committing to that and seeing the potential for what that infrastructure can do for healthcare delivery across the board, as well as really, thinking strategically about how to distribute the vaccines available in the right way. And we know we can do this. Rwanda is a terrific example. When HIV medications came online, originally back in the mid sort of, in the sort of, I don't know what they're called, aughts, 2004, 5, 6, the US would only pay, one of the largest funders of HIV vaccines would only pay for vaccines that were FDA approved, which meant second line ARVs. And that meant the first line that cost a lot less, had to be bought by somebody else. But the US administered certain sites. And so they ended up dividing the country, insisted on creating a system of distributing vaccines based on funders and who is available in a way that actually expanded the reach. Sorry, it wasn't vaccines, the ARVs, the antiretrovirals, expanded the reach of antiretrovirals faster, more effectively, and more thoughtfully to the people who needed which one in which place in the right way. And I think we are capable of doing that, but it takes compromise, it takes solidarity, and it takes a joint commitment to realize again that this is a fundamental and essential thing that we have to achieve in this moment, right? This isn't just about my well-being as, a powerful person living in New York City or wherever else, or Boston or wherever it may be. It's about our collective well-being and our ability to get past this moment. Because even if we vaccinate the entire United States, we're still not going to get back to normal. You can't travel. You can't leave this country. Nobody can come into this country. Goods can't come into this country. We can't live or exist in that way. And it's worth noting that the UK has bought enough vaccine to vaccinate itself 5 times over. Canada's bought enough to vaccinate itself, I think it's something like 9 times over. So we're talking about really sort of the wrong mentality to this moment.
Absolutely. And I think that we all within the People's Vaccine Alliance definitely agree with those perceptions and concepts around compromise, working together, and making sure that we can deliver this vaccine, but also better healthcare across the world and across everyone who really desperately needs it. Thank you all for joining in. We've run a little over time, so I'm going to wrap us up now, but thank you all for being fantastic panelists and joining the discussion. And thank you to the viewers for joining in to hear more about the People's Vaccine and the movement that we're building to really make sure that we can get to equitable access all over the world and really address some of the huge barriers that have been put into place by the current system. And yeah, it's amazing to share thought partnership with all of you and to hear all of your perspectives as we go.
Thank you so much, Justin.
Where healthcare is not a privilege, but a human right. Where care is not conditional, but guaranteed. Where no patient is left behind. For more than 30 years, Partners in Health has made it our mission to create this world. From the bedside to the halls of power, we have spoken up when world leaders fell silent, taken a stand when others wouldn't, delivered care once thought impossible, because healthcare can't wait, and neither can justice.